Good evening, everybody. As you know, Royal Pearl Hospital has always strived to be very academic and also always strive to teach everybody in and around the world and bring the best of the best in every field. Now we with Alembic have started on a very new mission, and this mission is called Meeting the Legends on a Saturday night. I'm sure on a Saturday night everybody will be in a different mood, but then let us have some really academic stuff going on maybe every fortnight on Saturday nights at 8 o'clock. So we're going to have a small video by Alembic, and I really thank Alembic for having done this program with us, and they have got a very good name in doing the master class. So we are also bringing a series of master classes with Royal Pearl Hospital this year, and also a series of Meet the Legends. So we'll have the video of Alembic, and then I will come back to you again soon.
Good evening, doctors. Myself, Jayakumar, Vice President, Alembic. Today I take this opportunity to welcome all of you for this great scientific feast, Connect with the Legends. Being a knowledge-driven global pharmaceutical company, at Alembic, our mission is to provide access to every practitioner and a specialist of the best minds in knowledge and the best hands at surgery. In an endeavor to continuously build new avenues for knowledge dissemination, today we, under the able guidance of Dr. Janaki Ram, open digital doors powered by Alembic as means to gain knowledge and connect with the legends of the ENT fraternity. Today at Royal Pearl Hospital, Trichy, Dr. Janaki Ram is hosting Dr. Jayakumar Menon. His stature is such which does not need any introduction. The day which we have chosen purposefully for all of you to log in, sit back, relax and be a part of the knowledge dissemination at its highest level involving legends of their area of expertise and specialization. Once again, doctors, I welcome all of you for this great scientific event. Thank you very much.
So as you saw, Alembic and Royal Pearl has now joined hands, and this year is going to be full of academics. To start with Meet with the Legends on a Saturday night, we have none other than the real legend in laryngology, and he is none other than Dr. Jayakumar Menon. And he doesn't need any introduction. He is a very world-renowned personality, and he is the teacher of teachers in the field of laryngology in this part of the world. He is actually a very dynamic and a very humble, a very nice person to move with, a very nice human being, as well as an encyclopedia of knowledge in laryngology. In fact, I learned all my basics in laryngology from Dr. Jayakumar Menon. He is one of the few in the country who is having a solitary laryngology practice. It's really proud to say that. I mean, he has got a dedicated department of laryngology in which 5 doctors are working round the clock to treat various problems in laryngology like airway, voice, deglutition and so on. So without much ado, we will start this Saturday night with Dr. Jayakumar Menon, sir. Welcome to Trichy, welcome to Royal Pearl, sir. And we are just eagerly waiting to hear your lecture, and the whole world is waiting for you. Over to you, sir.
Thank you, Dr. Janaki Ram. Good evening, all of you. Dr. Jayakumar is a very good friend of mine, and I wish all success for this wonderful teaching project he has undertaken, and I am sure that he will continue with this for a long time, even though I should say that I don't have any pretension of being a legend in laryngology. That is certainly not the case. I consider myself still a beginner. Ask anybody who has gone into any super specialty, they know that. I also have known that the more you learn, the more you understand that you have to learn still more and more. So it is an unending process. So I am only happy to share my experiences in laryngology, and if it is going to be useful to you, I will be more than happy. So with this introduction, we will go into the field of laryngology. Today we have selected 3 topics. The first topic is diagnosing laryngeal lesions, and the second will be on the vocal cord paralysis, and the last one will be on neurological dysphagia. So we will start with the first topic, that is diagnosing laryngeal lesions. We will start with the slideshow now. I think most of you know who is this personality. This is Manuel Garcia, who was actually a musician and then later became a voice trainer, and out of curiosity he actually designed a very ingenious technique of watching or examining the larynx. So that is how the first indirect laryngoscopy came into practice. Since then, so much of advances has happened in the diagnosis of laryngeal lesions, and that is going to be our topic. Now, even the first year postgraduate know that the basic examination technique for visualizing the larynx is the laryngeal mirror. But now this is being less and less used, even though it has got some advantage, like it is a very inexpensive thing. The color contrast is perfect, but the problem is that there is no magnification, and it's a fleeting view. You don't get real continuous picture to diagnose various laryngeal lesions, and especially it is not possible to do the laryngoscopy, indirect laryngoscopy in everybody. Some patient may be really have a very sensitive throat. So in that case, you may not be able to do the indirect laryngoscopy, however skilled you may be. So nowadays, predominant techniques of visualization of the larynx is by using the telescopes, either the rigid or the flexible, or ideally both. Actually, you should be having both. In the ideal scenario, you should be having both a rigid and flexible laryngoscope. Rigid is always superior in the clarity, even if you take into consideration the chip-on-tip camera, and hence they are best for identifying even the minutest of structural lesions. But flexible laryngoscopy has got some advantages over rigid scopy, especially when you are dealing with a movement problem of the vocal cords. So neurolaryngology conditions like vocal cord paralysis, tremors, spasmodic dysphonias, and of course the muscle tension dysphonia, where structurally there is nothing wrong with the vocal cords, but functionally they are abnormal. So for these two conditions, certainly flexible laryngoscopy is superior, but ideally you should have both, and many patients may require both of them. It all depends upon the individual cases and individual patient, whether you are able to see it properly. So you will have to take the decision. Now, the rigid scopy, there are many angles, but the most comfortable angle will be the 70-degree scopy, even though 90-degree scopy are also used. 70 degrees is the most convenient scope. So if somebody is just planning to buy a single scope, rigid scope, then you should be buying a 70-degree scope. You can use the classical 4 mm nasal endoscopes too, but you need better magnification in the larynx. So, ideal scenario will be a 10 mm 70-degree rigid scopy. That is the best scope for the laryngeal visualization. Now, with that basic introduction, we will see a lot of structural lesions. Some of them are fairly very common, some of them are uncommon, and some of them are very rare. And also, in the end, we will see few of the movement disorders, especially the neurolaryngologic and muscle tension dysphonia cases. So, we will start with the vocal nodule, which is probably the most common condition in a voice clinic. Can you play on that thing? So, this is the vocal nodule, classically so you can see that the two nodules at the usually they are this is little bit unusual in the sense that they are little bit asymmetrical. On the right vocal cord it is slightly posterior, on the left vocal cord it is anterior. That is nothing unusual about it. It can happen depending upon the tension the patient is keeping on the vocal cord on. But this is probably the most common condition in a laryngology clinic. Now, can click again. The vocal cord polyp is the second, probably the most common condition. It is a little bit different. While vocal nodule is always bilateral condition, vocal cord polyps are unilateral, and you can also see it is a reddish polyp. It usually is an organized hemorrhage. This usually happens in adults who shout at the top of their voice, and compared to vocal nodule, this is very rare in children and in ladies. Vocal cord cyst will be probably the third most common condition, but it produces probably the maximum hoarseness among the Reinke space lesion. The reason is that you can play on that. The reason is that while the vocal cord polyp and nodule are, it can be considered as an extension of the Reinke space. Here, the vocal cord cyst is actually containing liquid. So, and you just got different vibrating properties. So, you can see that there is hardly any vibration over the cyst, and it really produces a very unpleasant, rough voice. That is typical of a vocal cord cyst. Reinke's edema is luckily coming less and less in our, in our country, because I think smoking is not that common among the younger generation. Here you can see that both vocal cords are massively edematous. So the commonest cause is smoking. Of course, it can also occur in hypothyroidism and in severe laryngopharyngeal reflux. But the classical, this kind of waterlogged masses occur mainly in smokers only. So this is a typical finding. So all these conditions now we have shown a very typical telltale diagnosis. You can pick up the vocal nodule, the polyp, the cyst, the Reinke's edema. Now papilloma, you can play, continues to be a real thorn in the flesh for the laryngologist, despite all the tremendous advances in the field of laryngology. It can be a real frustrating condition. You can see the grape-like masses involving practically any part of the larynx can be involved. Here you can see it is on the left vocal cord mainly, but also on the right vocal cord, subglottis. It can go to the supraglottis, trachea, bronchi. It can be a nasty condition. Even though it is basically a benign disease, it can many times behave just like a malignant condition. So, a very, very difficult condition to treat. Even now, we don't have the final answer to correct this condition. Malignancy, unfortunately, is still not that rare in India. This is actually a very surprising case. This was a 27-year-old lady, which ladies are very unlikely to get laryngeal malignancies, but Nowadays we are seeing probably little more cases, maybe because of the influence of the HPV, even teetotalers are getting. But as in case of Reinke's edema, malignancy also is far more common in smokers. Now, this is the next two condition we are discussing is congenital. This is the glottic web. You can see anteriorly the vocal cords are fused together, and luckily most of these webs are not that serious. The only problem with the child will be, you can play once again, a high pitched sound. Very rarely they produce a airway obstruction. If they do produce airway obstruction, they are emergency, they need to be treated much earlier than that. Otherwise, if it is a purely a voice problem, we can very well wait up to the age of 2 or 3 years, and then only you need to operate. Now, sulcus is a relatively new diagnosis in laryngology. Only when the laryngology developed as a speciality, this existence was known. You can see that the medial margin of the both vocal cords are scarred and hardly any mucosal waves are there. Very little mucosal wave anteriorly, very little mucosal wave posteriorly, and you can hear that voice, the classical high pitch, breathy, strain voice is typical of sulcus. We don't know the cause, but it is much commoner in Asia than in Europe and America. Probably India has got a very, very high incidence of sulcus vocalis. We really don't know what is the etiopathogenesis of it. Vast majority, more than 95% of them are congenital. So there is some problem with the development of the Reinke space. Now, this is vocal process granuloma, not a rare condition. Again, you can see on the right side here, there is a polypoidal mass just medial to the vocal process. The good thing about this is that it is very exceedingly rare for that area to develop a malignancy. So people who are not familiar with this condition might even think about that being a malignancy, but vocal process region is very, very, very extremely rarely only develop vocal process malignancy of that region. So this is a classical vocal process granuloma. Can you play that once again? This is usually secondary to a wrong style of voice production where the person has got too much of force on voice production. And if it is coupled with laryngopharyngeal reflux, which is fairly common, the mucosa become highly inflammable, and due to the persistent forcible contact, some grade of perichondritis develops. Secondary to that, patient develop vocal process granuloma. Since it is in the posterior part, very rarely only patient have significant voice problem. Now, this is a very, very common diagnosis, probably even overdiagnosis. You can play that. This is the laryngopharyngeal reflux disorder. There are many classical signs, but this is the most important sign. If you watch carefully, you can see there is a protuberant mass between the arytenoid, that is the interarytenoid pachydermia. Almost it looks like a polyp. Why I am showing this picture is that if people are not familiar with this condition, they might think this is a posterior glottic polyp and even might attempting to remove it. Nothing can be more dangerous, because that is a very, very important area. If you traumatize by doing a surgery in the interarytenoid region, that will invariably end up in a condition known as the posterior glottic stenosis, which require far more difficult surgeries to correct. So if you see a finding like this, be sure that it is most likely interarytenoid pachydermia, secondary to constant bathing of the arytenoid region from the acid. So usually they respond very well to the proton pump inhibitors and anti-pepsin agents. Submucosal hemorrhage is not a rare, no, go back, okay, play on it. Yeah. You can see that compare the color of the left vocal cord and the right vocal cord. The right vocal cord has got very bright red color in the vocal process region and near the anterior commissure, and in between there is some yellowish color. That is an old hemorrhage. The red color is the fresh hemorrhage. This usually happens if somebody shouts at the top of their voice, and also it can happen in ladies during their premenstrual period. During the premenstrual period, because of the effect of the progesterone, the vocal cord become waterlogged and the chance of capillary tear and bleeding is high. This is one condition which require absolute voice rest, because if the voice is being continuously used, the vocal cord hemorrhage can easily become a vocal cord polyp, further requiring surgery. This people may not be very familiar, so many of the lesions you saw are very familiar to most of you. This is what is known as the capillary ectasia. Watch the superior surface of the left vocal cord. So varicose vein like structure, actually we like varicose veins of the vocal cord. Its only difference is that it is actually not a vein, but it is a capillary. So people who really strain at their voice can develop many times this kind of tortuous capillaries, tortuous blood vessels on the superior surface. Mind you, this is not on the medial margin. So generally these people won't have much of a voice problem, but their main complaint will be easy fatigability, and the danger is that they can bleed at any time, resulting in a hemorrhage. So even though they are asymptomatic, if it is really big, they are better treated by laser cauterization. Now, tuberculosis is still not very rare in India. Actually, on the other hand, it is on the resurgence. There are many cases of multi-drug resistant tuberculosis, and this is a classical finding of tuberculous laryngitis nowadays. That is the monochorditis. You can see that right vocal cord is normal, but the left vocal cord is reddish, slightly granular and irregular. If you examine it under microscope, you can even see the granular nature of that lesion. This is almost typical of the tuberculous laryngitis. Stroboscopy shows some amount of mucosal wave, but it is still reduced when compared to the normal side. There are other signs like turban epiglottis, multiple ulceration, but they are nowadays very rarely seen. So a unique monochorditis, unilateral congestion of the vocal cord, if you come across, especially in the absence of a scenario suggestive of submucosal hemorrhage, you should strongly suspect tuberculosis and do the basic investigation to rule out. Most of them are secondary to laryngeal pulmonary tuberculosis. Sometimes you can have primary laryngeal tuberculosis too. In that case, you may have to take the patient to the theater, do a submucosal biopsy. Now, whenever you see an unusual type of mass, very smooth mass, always keep the diagnosis of amyloidosis in your mind. Amyloidosis is certainly not that rare. So this look like a polyp, but we knew that is not a classical polyp. And amyloidosis can present anywhere in the larynx. It can be in the subglottis, it can be in the glottis, it can be in the supraglottis. So a smooth surface, unusual mass, especially if there is an yellowish color, then you should think that it could be amyloidosis. This was a supraglottic amyloidosis. You can see that there is a big mass on the right side supraglottis. The important thing in making the diagnosis is that unless you write down the clinical diagnosis as amyloidosis, the pathologist will not many times do the specific test for the amyloidosis, and the diagnosis will be missed. So any suspicious smooth surface lesions, especially if there is an yellowish tinge, always think of the possibility of amyloidosis.
Sir,
yes.
I have a few queries actually. Let us make it more interactive.
Okay.
Because let the people also ask questions.
Sure.
We have a few questions. One from Dr. Rajendran Dinesh Kumar.
Yeah.
Good evening, sir. Unilateral vocal cord granuloma. How long would you manage medically with PPI, and when would you contemplate surgery?
Vocal process granuloma, you should treat adequately with proton pump inhibitors for at least 6 weeks, and also they should be counseled regarding the voice usage. If your diagnosis is very sure, there is no need of surgery, you can actually give Botox, because Botox is the treatment. the vocal process granuloma is actually secondary to a perichondritis, and if you want to perichondritis to subside, you have to give absolute voice rest. So you give Botox to both thyroarytenoid muscle, and in 2 to 3 weeks time you will see that the vocal process granuloma totally disappear.
So one more question by Dr. Loknath Sahu. What causes granuloma most common in your practice, and who you treat in case of WHO, you treat in case of tuberculosis? So what is the common cause of granuloma you have found in your practice?
I suppose he is asking about the vocal process granuloma.
Yes, yes.
Vocal process granuloma, there are two major factors. Which is the major? We are not very sure. But the two major factors, one is the continuous bathing of the laryngeal mucosa by the acid so that it becomes very inflamed and fragile. And the second is the style of talking. People who speak in a much lower pitch has got the tendency for the vocal process, the vocal process of the arytenoids to hit against each other. So already inflamed because of the acid reflux, it became ulcerated and the cartilage get exposed. The cartilage is very, very submucosal there, and constant hitting actually result in a small amount of perichondritis, and that is the cause of granuloma.
And one more question from Dr. Deepak Dalmia from Bombay.
Yeah.
If HPE shows only giant cells and Langerhans cells but no AFB, can we start AKT? So that is a question.
Yeah, that's a presumptive. You will have to discuss. You will have to discuss with the pathologist. You will have to discuss with the case and also with the pulmonologist. If there is no other diagnosis, there is no conventional treatment is not curing. And if the chance of the other parameters of tuberculosis is high, then you will have to treat. I generally get an opinion from the pulmonologist too. So if it is a soft granuloma, go ahead and treat as tuberculosis.
Okay, one more question from Dinesh Sharma. Can both vocal cords be involved in tubercular laryngitis?
Certainly, there is no reason why it shouldn't be, but we actually don't know why it happens on one side. Maybe it is the position, maybe it is the position patient is assuming, maybe it is the reason why one particular side is affected, lower respiratory tract, it is causing the bathing of the vocal cord. If there is bilateral lesion, there is nothing to suggest that it cannot be tuberculosis. Actually, I myself have a case where both vocal cords were involved.
You can carry on, sir.
Yeah. Now, this is a very rare condition. I think in Kerala it is very high, but a laryngeal rhinosporidiosis is exceedingly rare. Very few cases have been reported. This patient came with incredible stridor. She couldn't sit, she couldn't stand, and we were planning to do the tracheostomy because she couldn't do and she couldn't sit comfortably at all. But then the anesthetist put down a laryngeal mask anesthesia and tried to control it. And through the laryngeal mask, I could pass the flexible laryngoscope, and to my surprise, I saw a huge mass of rhinosporidium coming from the immediate subglottis, coming like a ball valve. Each time patient was exhaling, that was coming out of the glottis and causing an obstruction. You can see it in a few seconds time. So that was causing a real trouble for the patient, and actually we could do the removal of the laryngeal mass endoscopically itself. You can see that actually we are going with the flexible laryngoscope through the camera there, and there was a fairly big mass between the arytenoid, and without tracheostomy actually we could remove it. We could first decompress, and then we could intubate with a, you can see that it was a fairly very big mass. It was an old video, that is why that quality of that picture is still not very good, but you can still see that is fairly a huge mass each time coming out of the vocal cord, massive rhinosporidium, almost completely obstructing. But we could remove it without a tracheostomy, then put the laser tube and completely laserize the pedicle, which was in the just below the anterior commissure, and patient was actually discharged next day without any tracheostomy. She is free of the disease now for more than 5 years. So rhinosporidium in an area where rhinosporidium is endemic, and especially if patient had multiple rhinosporidium operation in the nasal cavity, you shouldn't be surprised if you see a lesion like in the larynx. You can actually get rhinosporium of the larynx too. So that is not rare, but where areas, I don't think it is very common in the North India. It is fairly common in Kerala, Sri Lanka, and other parts of the South India. So in this region, you have to keep that diagnosis also in the mind. Now, you can occasionally get rare tumors. This was a 12-year-old girl who presented with persistent hoarseness, and this was the finding. You could see that the right vocal cord even is not normal. In the infraglottis there was a swelling, but the left vocal cord was totally abnormal. It was swollen spindle shape, and I again thought maybe it was amyloidosis. There was some yellowish tinge, so I kept in the mind, but I excised it, but it came back as a granular cell tumor, which is actually a benign condition, but little bit difficult to control. So she is right now okay. I did operation only on one side, waited for the area to heal, and then went for the other side. Now, this is a classical finding of laryngeal sarcoidosis. If you haven't seen it, once you have seen this picture, you will not miss this diagnosis. So the epiglottis will look like a tire, exactly like a tire, the cut across the 3 o'clock to 9 o'clock position, a semicircle. You see that it's massive. This is the classical finding of sarcoidosis of the larynx. You can see it's classically the supraglottis will be involved. There you can play once again that the arytenoids, the aryepiglottic folds, they also can be quite swollen, and vocal cords you can actually get a glimpse, they are normal. You can see that that is normal, but look at the arytenoid, look at the epiglottis, so thick, and the patient's main symptom is like a hot potato voice. Otherwise it is not hoarseness, but her main symptom was sleep apnea. She couldn't actually sleep well. So there are different treatment. Once you diagnose it, you can actually do laser debulk it. There is a surgery known as the pepper pot laryngoplasty. Like a pepper pot, you puncture multiple pores into the epiglottis, so it becomes shrunken later, and you can even do a partial epiglottectomy.
Sir, I have a question.
Yeah.
Can I ask a question, please?
Yeah.
One question from Loknath Sahu.
Yeah.
Post-op rhinosporidiosis, how much dose of dapsone and how long you will give it?
We don't give dapsone anymore. That is that was the previous practice. Right now we don't remove it. The best chance of cure for the rhinosporium is that you completely thoroughly excise it. With the newer gadgets like coblator and laser, actually that has become easier. Now the difficult cases are only those cases which were operated years back and who got multiple pedicles. The newer cases, especially coblator, is a fascinating equipment for that because it doesn't allow bleeding. It has got a big working area. You can actually cauterize all around. So first treatment is the best treatment. We don't give dapsone now.
There's one more question
From Arun, Dr. Arun. He says that he has operated on a case of recurrent squamous papilloma of both vocal cords with laser, following which he has developed a massive web, aggressive web. So what will be your line of management in this case?
Yeah. First of all is prevention. When you get the papilloma, it is always safer to operate on one side. Never go near the anterior commissure and operate on both sides. It will invariably develop a web. So stage it. You excise on one side completely and on the other side only the posterior half. Don't go near the anterior half. Wait for the epithelium to heal back. That is around 2 to 3 weeks time. Take the patient again for the surgery and do it on the other side. Once web is formed, the treatment is decided depending upon the fact whether the condition is under control. If papilloma is still active, no point in dividing the web. It is not going to cure. Once the papilloma is well under control, maybe say 6 months or even 1 year, no evidence of any recurrence, then you can treat just like any other web. You divide it, you can put a keel, there are a lot of techniques.
So one more question from Chiranjib Das. Do you cauterize the base in case of rhinosporidiosis originating from vocal cord?
Yeah, I use the laser because you cannot really use the cautery. Cautery is too damaging for the vocal cord. And even coblator you shouldn't be using on the glottis. You can use it on the subglottis, on the supraglottis. Vocal cord is too fragile a structure to stand the injury caused by a monopolar diathermy or a coblator. You can use a bipolar laryngeal diathermy, great. but the ideal scenario will be the laser.
Okay, sir, you can continue, please.
Now, presbylarynx. As laryngology is fast developing, this is becoming a hot topic. If you can do facelift, there is no reason why you can't do a voice lift. You know, older people, they will come say that, you know, my voice is weaker. You can see the vocal cord is atrophic. There is a spindle-shaped phonatory gap. You can see big ventricle because the vocal cord is atrophic, very prominent vocal process, and the vocal cords are not actually completely closing. So various types of presbylarynx you come across now. People previously didn't know that they can be treated. Now we can actually treat, we can bulk it, we can do proper voice therapy, we can give injections. A lot of treatments are there. Even you can do thyroplasty. So this is quite a hot topic in laryngology nowadays. Now we'll come to the flexible laryngoscope also. This is just showing. I will be also showing in between the rigid scope. Now many people will have asked me that when I am starting a laryngology clinic or a voice clinic, which instrument I should buy? The first answer is that depending upon the budget, most of the time your budget may not be very great. So what you should do is that you should buy a pediatric flexible laryngoscope. Why pediatric? Because with the pediatric you can do more, not only pediatric scopy but also adult scopy. And rigid scopy you can buy later. Now you know that the quality of the second picture, that is the chip on tip camera, that gives a super quality. It is almost as good as the rigid scopy. So when your budget is allowing you to buy bigger equipment, you can certainly buy the chip on tip. But when your budget is very, very limited and you want to start the clinic, if you are going to buy, you always buy a conventional flexible laryngoscope with a pediatric diameter, something like a 3.2 diameter, and preferably without a suction channel, because suction channel takes away the clarity many times. So if most of the time you need only diagnosis, but when you have got more money and more budgeting facility, you can buy all those instruments. Now, where is the indication for the flexible laryngoscopy? So we told mainly it is the neurolaryngology and the muscle tension dysphonia. What is neurolaryngology? Where there is problem with the neurological function of the vocal cord. So it can be a bilateral vocal cord palsy, it can be a unilateral vocal cord palsy, it can be a superior laryngeal palsy, it can be a tremor, it can be dysphonias, so many conditions. You can see this is the bilateral cord palsy, and see the glottic space, how much is the glottic space. Why you should be doing a flexible laryngoscopy? There is no harm in doing a rigid scopy in these patients too, but the problem is that sometimes, not always, sometimes the rigid scopy might give wrong impression about the movement of the vocal cord. So if the clinical picture and the symptom, the endoscopy picture and the symptom don't tally with each other, then you should always think of doing a flexible laryngoscopy too. Otherwise, no harm in doing a rigid scopy in neurolaryngology also, but when in doubt in neurolaryngology and muscle tension dysphonia, you have to do a flexible laryngoscopy. In structural lesion, there is no need to do a flexible laryngoscopy. Rigid scopy gives excellent picture. You are not bothered much about the movement. Now, unilateral vocal cord palsy, you can play again. So you have seen the bilateral vocal cord palsy. You can also see the unilateral vocal cord palsy, how each vocal cord is moving there. See that the right vocal cord is moving, the left vocal cord is immobile. But you can see that there is no significant arytenoid asymmetry. When patient is speaking, the arytenoids are fairly symmetrical. That say that it has got fairly very good voice, and at the most patient is going to require only thyroplasty, no arytenoid rotation. So these things are probably better seen with the flexible laryngoscopy than with the rigid laryngoscopy. You can also see the structural lesion with the flexible laryngoscopy, no problem, especially if you have got a chip on tip, that is great. But of course, rigid has got a much bigger diameter, more number of fibers, so quality will be always superior. Now, this is again another very important topic in laryngology. Previously, we knew only about the vocal cord palsy. Now, we know that there are many cases where there is no complete paralysis, but partial paralysis, or what we call paresis. So different kinds of vocal cord palsy can occur, with the result that now the terminology itself is now changing, because we don't know whether you should call it palsy or paresis or synchinosis. Vocal cord has got a high tendency for recurrent laryngeal regeneration, resulting in unwanted type of neural anastomosis, abductor going to the adductor. So some amount of regeneration always happen. So there is a tendency now to internationally to classify all this as impaired vocal fold mobility rather than palsy or paresis. But for the time being, we will just continue with this only. Can you play that again? Now watch this finding. How you diagnose paresis? Sometimes it is very easy, sometimes it is not very easy. Here you can see that the right vocal cord is moving, left is not moving that well. Sometimes it may be even subtle. So how will you then diagnose? If you see a phonatory gap, you play once again now. If you see a phonatory gap and see one arytenoid moving across the midline, watch the left arytenoid meets across the midline. That means the left side is partially paralyzed. So don't think that just because the left arytenoid is going across the midline, the right is paralyzed. It is actually the left side is paralyzed. Why? Because the interarytenoid has got bilateral nerve supply. The right is normal. It is powerful. It is actually pulling the left arytenoid to the normal side. That is why the arytenoid crosses over the midline to the normal side. Now, a very similar condition, many times you see this condition, overriding arytenoid. So people don't know whether this is normal or abnormal. Here you can see that the arytenoids are overriding, but vocal cords are meeting in the midline. There is nothing, patient doesn't have any voice problem. If you see something like that, you take it as normal, because 10% of the population is said to be having an overriding arytenoid. But watch the other overriding arytenoid on the other side. Now, here there is it is just like the previous case. This is actually a paresis. You can see that the right arytenoid is crossing over the midline, but there is a phonatory gap. So this is actually a paresis. So when you see overriding arytenoid, you should think about the two possibilities. Some, it may be normal. If there is a phonatory gap, you should understand the arytenoid on the paralyzed side will actually cross over the midline. And especially if they have got hoarseness, you should think that it's a subtle vocal cord paresis. Vocal cord paresis can be a very, very difficult condition to diagnose for the inexperienced. But I hope these two signs will help you in the future. If the arytenoid is crossing over the midline, that is due to the unopposed pull of the powerful arytenoid. It is like a tug of war. Imagine you are doing a tug of war from two groups. One group doesn't have the good foothold. They are in the loose stand. What will happen? The people with the good foot stand will actually pull them to the side. Same thing happens in vocal cord paresis. The stronger arytenoid will pull the weaker arytenoid to the side. So that is a sign of vocal cord paresis.
Question, a couple of questions. Dr. Yogesh has asked, what is the common cause of sudden onset unilateral vocal cord palsy?
Unexplained unilateral vocal cord palsy, most of them end up as actually idiopathic, vast majority. So the current theory is that they are viral. There are centers where you can actually do viral study, even they may not yield the desired result. But what we have to do is that we have to rule out, we have to make sure that we are not missing any serious lesion. So any vocal cord palsy, unexplained unilateral vocal cord palsy should be scanned. The whole root of the recurrent laryngeal nerve should be scanned. So you should take a scan from skull base to sternal angle. Vast majority of them are actually idiopathic. They may be viral, but you should be very careful about mediastinal lesions. Too many of the mediastinal lesion can actually present with vocal cord palsy. Skull base lesion producing unilateral vocal cord palsy is not that common.
One more question by Dr. Santosh Kumar Swain. Is stroboscopy compulsory for starting a voice clinic?
Yeah, I was coming to that. I even though I showed most of the picture as stroboscopy, I actually was talking only about the flexible laryngoscopy and the rigid laryngoscopy. Stroboscopies can be only a late addition. You need, when you are starting your clinic, I don't think you should buy a stroboscopy. because they are important only in diagnosing the vibration pattern. So there are certain conditions like sulcus vocalis, early malignancy, they are important, but I will advise any youngster, don't bother much about the stroboscopy in the beginning. Make a very good endoscopy so that you can get a very clear picture.
So we have one, just a comment that we are being seen by 3,961 people. That is roughly 4,000 people across the world.
Great.
And it's a very great number. I just want to ask one question by Dr. Prakash Munka, my very close friend. Most of unilateral vocal cord palsies compensate and does not require any treatment. Your comments, sir?
Yeah, in a vocal cord palsy, we are understanding it better and better. Now we know that when the vocal cord gets paralyzed, there some amount of regeneration invariably happens. And the regeneration can actually go in different directions. Sometimes the adductor may be predominantly regenerated, sometimes the abductor may be regenerated. So depending upon this, vocal cord can get fixed in new 3 positions. Sometimes it may be in adducted position, that means paralyzed vocal cord is in adducted position, the other vocal cord has no difficulty in meeting it at all. So patient have near normal voice. They don't require any treatment. The second group, the paralyzed cord get fixed in neutral position. Their voice will be little bit weak, maybe MPD around 8 seconds, but their voice won't be very bad. And many times with voice therapy and positioning of the neck, you can actually improve the voice. But the third group, where the vocal cord get fixed in abduction, they have got very, very poor voice, they need surgery. And one point is that we have been talking for years that the other vocal cord compensate. There is nothing like that. Actually, the vocal cord really cannot come too much across the midline. It is what we thought as compensation is actually the final position of the regenerated vocal cord. You know, I told about being fixed in the adducted position. So there is a limit for the opposite cord to cross over the midline. It cannot do that. So that is the reason why some people don't require any surgery.
So that means your conclusion is that there is nothing like compensation at all. That word should be removed.
Yeah, right.
Okay, thank you. Carry on, please.
Now, this is a very, very rare condition, but unless you are familiar with that, you will miss it. The classical keyhole-shaped phonatory gap, this is an interarytenoid paralysis. And if you watch carefully, you can see there is a big gap between that arytenoid posteriorly. Now watch, when you see the next video, watch that area. That will get completely closed. The arytenoid will come close to each other. Here there is a big, shallow, yawning gap between the arytenoid. This is the interarytenoid paralysis. Again, very rare condition, very difficult condition to treat because there is no method as of now to correct the interarytenoid paralysis. You can fix one arytenoid, but you can't fix both arytenoid. If you fix both arytenoid medially, patient will have severe stridors. You can see that classical triangular gap. This is a rare condition. We don't know why some people have got interarytenoid paralysis because interarytenoid is quite unique in the sense that it has got a bilateral innervation. Now, superior laryngeal is again a subtle condition, very difficult to diagnose unless you are very familiar with that. Even a familiar people can actually get confused. One important sign will be a relatively transverse aryepiglottic fold. Watch, the right aryepiglottic fold is more anteroposterior while left is at an angle. You can see that while patient is actually producing sound on the high pitch sound, you can see that left aryepiglottic fold is getting more and more transverse. You can appreciate that now, and the left vocal cord is bowed also. This is a very subtle sign. If it occurs bilaterally, it can be very difficult because you can't compare with the other side. You know that anybody who is familiar with a bilateral palatal paresis, it is very difficult to diagnose. If it is a unilateral, you can always compare with the other side. Similarly, a unilateral superior laryngeal is relatively easy. The right is anteroposterior, left is transverse. Myasthenia gravis. This is not the classical picture. Any bilateral paresis can present, but myasthenia also will present like that. They will have a fairly weak voice, and you can see that patient doesn't have any breathing difficulty, but the adduction is very, very poor. And they have got some swallowing problem also. You can see there is some amount of saliva in the pyriform fossa. See that plenty of saliva actually. her swallowing also is affected, and you can see the both vocal cord adduction is very, very weak. This is, I will not say that this is the typical myasthenia gravis finding, just like the previous slide, but myasthenia, mind you, never, always keep myasthenia also in your diagnosis when you come across unusual vocal cord paresis. But you, they may be unilateral, they may be bilateral, and especially if it is combined with the swallowing problem, you should strongly suspect that condition.
Sir, I have a question from Dr. R.K. Jha. Whether vocal cord polyps can be medically treated?
There is no medical treatment. Vocal cord polyp is actually a organized hemorrhage. So, but in the early stage, when the vocal cord polyp is blood red, very reddish, if they take absolute voice thrust, they will actually resolve. Many of the smaller polyps will resolve. You can certainly give PPI as well as some enzymatic preparations, but I think the major role is absolute voice thrust. But very, very few people can actually practice absolute voice thrust for 2 weeks. If they do, very well. So there is no harm. There is always time. Vocal cord polyp is not a serious condition. No harm in attempting conservative management for 2 or 3 weeks. If it resolves, well and good.
So we have a question from Ranbir Singh. How often aspiration is a problem in vocal cord palsy? How often?
Unilateral vocal cord palsy, recurrent laryngeal nerve palsy alone is very, very unlikely to produce aspiration. I can put it this way. Now there are 4 major nerves related to swallowing: glossopharyngeal, hypoglossal, superior laryngeal, recurrent laryngeal. So unless there is more than one nerve involved, aspiration will not generally happen. So if it is a combined high vagal palsy, chances of aspiration is high, because superior laryngeal is gone, recurrent laryngeal nerve is gone. If there is a hypoglossal palsy with a recurrent laryngeal nerve palsy, chance of aspiration is there. Isolated recurrent laryngeal nerve palsy hardly ever produce. Even if it produces, maybe post thyroidectomy 1 or 2 days, they may have some cough during water intake, but generally they won't.
So just a comment, more than 5,100 people are watching it. I just want to tell you that there are so many questions pouring in. We may not be able to answer all the questions. We will try to answer most of your questions. Over to Dr. Jayakumar sir now.
Now, spasmodic dysphonia is not a rare condition at all, but important thing is that unless you know about it, you won't diagnose it. You don't require stroboscopy, you don't require actually anything. You can see that this is a tremor with spasm, but towards the end you can see the classical spasm. That is a spasm. In between he is going. So in between you can see that that again spasm. In between you can see that that's a classical adductor spasmodic dysphonia. But I will tell you, let me tell that the most important diagnostic tool is an experienced person. Only if you have heard spasmodic dysphonia early, you will diagnose. Otherwise, whatever equipment you have got, you will not diagnose it. That is very important. So, if you have heard the spasmodic dysphonia, it is not very difficult. When you do the Scopy, you will see that in between there is spastic hyperadduction. That is a classical adductor spasmodic dysphonia. Abductor spasmodic dysphonia is much rarer. Here you actually, instead of adduction, in between you see lot of abduction. See that? Hardly ever the vocal cord completely closed. That is all abductor spasm. See that even when patient is producing the sound, there is some amount of gap between the membranous vocal cord. That is the classical abductor spasm of abductor spasmodic dysphonia. It is not that easy to diagnose abductor spasmodic dysphonia unless you know it. Of course, I myself have described a sign which is invariably present in all cases of abductor spasmodic dysphonia. At the time of abductor spasmodic dysphonia, patient will have flaring of LNSA. That is a very, very almost always present sign. But since it is an endoscopy finding, I am not showing it here. Now, it is very similar to adductor spasmodic dysphonia, but watch the difference. In laryngeal tremor, the whole larynx shakes. You can see that it is not just vocal cord, the epiglottis, the arytenoid, the aryepiglottic fold, the pharynx, everything is shaking. Otherwise, voice wise, sometimes if you are not experienced, you may think that this is adductor spasmodic dysphonia. This is actually laryngeal tremor. The whole the larynx is tremulous, and many of them will have even tremors of the hand and all. So if you see this finding, you should make sure that this is vocal tremor. Of course, both can be treated with the Botox. Now coming a few words about the muscle tension dysphonia, means vocal cords are normal. So what is a normal phonation? There are three requisites. There shouldn't be any phonatory gap. There shouldn't be any supraglottic phenomena. That means neither the ventricular band nor the arytenoid come, and the aryepiglottic fold should form a pointed arch. Can you play once again? Say that absolutely no phonatory gap, no ventricular band adduction, and look at the aryepiglottic fold, pointed V. This is the classical normal definition of a normal phonation. Now you can get different types. There is classification like type 1, type 2, but what I am just telling is descriptive terminology. This is the ventricular band adduction. He is actually a Kathakali singer. You can see as he go to the high pitch, he go for unbearable ventricular band tension. Totally obstructing the view of the vocal cord. This is severe ventricular band dysphonia. So that is why again it is better you do a flexible laryngoscopy rather than a rigid scopy. Each time patient sing for the high pitch, it simply go over reduction of the ventricular band. That's a classical ventricular band dysphonia. Many singers will have this kind of problem. Now you can have another muscle tension dysphonia known as the anteroposterior compression, especially people who want to speak in a much lower pitch, bass voice. Watch, this will be the finding. Each time patient phonate, the arytenoid come much closer to the epiglottis, so that you can see only at least half or even 1/3 of the vocal cord only. Rest of the vocal cord is not visualized. This is not very common in India, but this is much more common in Western world, where even low pitch breathy voice is considered very attractive for the ladies. In India, we don't consider that kind of voice that attractive, so probably they don't develop that. But in Western country, type 3, this is known as the type 3 muscle tension dysphonia or anteroposterior compression.
So we have a question from Dr. Ritesh sir. Can we take the question?
Yeah, please.
Best PPI in your experience?
I think if you ask, I myself have asked this question to many gastroenterologists. I don't think there is any real answer. They all are good. They are probably very good. I use pantoprazole 40 milligrams twice daily for 6 weeks. And once the situation is under control, I actually shift to rabiprazole once daily, because it is it has got a relatively longer duration of action. But there are many gastroenterologists who prefer esomeprazole and omeprazole. I think there are no studies saying that one is superior.
So that is from Dr. Ritesh. Another question from Dr. Anil Reddy. He's a beginner and he would like to know if 70-degree endoscope or 90-degree rigid laryngoscope is better,
70.
or a flexible one is better than both.
70 is easier. 70 is easier. But I told in the beginning, when you are starting a clinic, buy the flexible. That is easier. So you can see every patient with that. Rigid scopy, you can't do it in everybody. In a child, you can't do that. So when your practice is beginning, buy a pediatric flexible laryngoscope. When you are buying a rigid scope, buy a 70-degree.
And one more question by Dr. H. Ravi Kishore, Bellary, Karnataka. Reason concept about phonatory gap.
Phonatory gap can be due to a structural problem, it can be due to a functional problem. Structural problem means the vocal cord is atrophic, so it can be due to sulcus vocalis, it can be due to vocal cord atrophy secondary to infection, it can be secondary to presbylarynx. Functional causes will be where the vocal cord is bowed. So the classical will be superior laryngeal nerve palsy, then the finding we just now saw, the anteroposterior compression. When the anterior and posterior ends of the vocal cord come closer to each other, the vocal cord bow, so there is a phonatory gap, and in abductor spasmodic dysphonia. So you have got both structural and functional cause. Phonatory gap is not a diagnosis, it is a finding. You have to identify why that phonatory gap occurred and then treat.
So Dr. Siti, she is from Indonesia. She came here for a training. She says that This is a very useful and very nice lecture, and it should be there always on the Facebook. Yes, definitely we will do it, Dr. City. Now over to Dr. Jayakumar, please.
Now, puberphonia is again very, very common in India, especially in South India. Kerala, it is very common. Where I had my laryngology training in Ireland, where hardly in Western world it is very rare. It is much common in India. You can see that this is a classical picture. Normal vocal cord, but a falsetto mode. It never actually totally touches. So, or sort of a parallel phonatory gap and a very high pitch voice. Can you play once again? And we'll have a very high pitch voice. So, when you get a high pitch voice in a male, the only other diagnosis you have to rule out is a sulcus vocalis, because sulcus can produce. But here you can see that the medial margins are very sharp, but it is not, it is always moving in the falsetto mode. Now, this is a huge topic, but because of the time problem, I am just stopping with one slide. People can have normal speaking voice, abnormal singing voice. That is the most common complaint. Singer will tell that, no, when I speak, my voice is okay, but when I sing, I have got all kind of problem. So, patient can have muscle tension dysphonia, all the muscle tension dysphonia, like ventricular band dysphonia, androposterior compression, when they sing only. So, that condition is known as dysodia. That means singing voice is abnormal, and you can get even other finding. Watch this, she is a very famous singer from Kerala. When she sings high pitch, you can see the pyriform fossa is squeezing. So, this is known as the pharyngeal squeeze. See, normally you should be seeing, that is abnormal. When she is producing high pitch, you can see that her pyriform fossa get obliterated. That shouldn't be the case. When you are singing high pitch, if you are obliterating the pyriform fossa, then patient won't be able to produce much finer subtle changes of the vocal cords. That is very difficult. That is what they call sangadis and plants and things. That they cannot do that. So this is known as the pharyngeal squeeze. See that when she is going for the high pitch, that's a wrong technique. See that again they squeeze. So this is the classical pharyngeal squeeze. This is a type of dysodia. There are loads of abnormalities in singing voice. We cannot go for that. That is a huge topic. That alone may take even 1 hour. Finally, occasionally you may be forced to do an examination under anesthesia. This is very rare when your diagnosis, even with the rigid or the flexible laryngoscopy, is not very sure. Very rarely you may have to do an examination under anesthesia. Of course, this turned out to be only a papilloma, grape-like lesion, but usually you can diagnose almost all laryngeal lesion with the flexible laryngoscopy and rigid scopy. If you have got stroboscopy, great, because you can study the mucosal wave pattern. Occasionally you need to do the examination under anesthesia. So, yes, in essence, it is actually, you should know, ears won't hear and eyes won't see what brain doesn't know. So, first of all, you have to teach your brain this condition is there. If you are not familiar with spasmodic dysphonia, you will not diagnose, however better instruments you may have. So, it is like Holmes told, pay major attention to minor details, minor attention to major details. Vocal cord polyp, everybody will pick up. In a huge vocal cord polyp, it is not an issue at all. But only if you look into a very carefully, you will find a small lesion like a small sulcus or a capillary ectasia. So always cultivate that habit of studying the laryngoscopy finding again and again. So later you will become a very good clinician. Thank you.
So a very brilliant lecture. That was the first of the 3 lectures of today, and in fact we have been seen by around 7,000 viewers all around the world. So really a great program, Dr. Jayakumar sir.
Very nice
and
to hear that.
7,000 people are watching you. And now we'll go to the second topic without much delay, and that topic will be taken over by Dr. Jayakumar Menon again. And we are ready to answer a few of your questions, because we can't answer all of them because there are so many coming in. And over to Dr. Jayakumar Menon on vocal cord palsy.
Now we go to the topic of vocal cord palsy. Again, a much bigger topic. But what we are going to do is that we are going to cover both the unilateral and bilateral. This is the Kerala Institute of Medical Science in Trivandrum, where I work, where we have got the laryngology department. Now, in the previous lecture, I told that nowadays we call it impaired vocal fold movement rather than vocal cord palsy. It is the better terminology because occasionally the immobile vocal cord may be due to a cricoarytenoid joint dislocation, a subluxation, ankylosis, interarytenoid ankylosis. Lot of things can happen. So when you see a immobile vocal cord, you can actually call it only immobile vocal cord. You need further investigation to definitely tell that this is actually a joint problem or a neurological problem. Now, unilateral vocal fold movement, idiopathic vocal fold movement problem. So what you do is, just like in any other case, take a detailed history, special emphasis on the onset, whether it was gradual or sudden. We described early, the sudden onset, and also ask whether it is a progressive or non-progressive. Progressive means some lesion is going on. So that is very important. And always ask about the past history of head and neck surgery, cervical spine surgery, CT surgery, cardiothoracic surgery, intubation and ventilation, systemic disease like diabetic mellitus and rheumatoid arthritis. This was a patient who actually underwent cholecystectomy, and after surgery he came out with vocal cord, immobile vocal cord. So that is not rare. This is actually described. After general anesthesia, sometimes overinflation of the bulb, of the endotracheal bulb, can actually cause shearing force on the tracheoesophageal groove and can actually produce vocal cord paresis. Luckily, they are temporary, they can actually recover. But also after general anesthesia, it is not very rare to have a vocal cord arytenoid dislocation, so be careful about that too. Now, unilateral vocal fold, that I is instead of L, that is a wrong mistaken printing. Anyway, never miss the basic investigation like X-ray chest. These are the two cases where actually the clinician missed the diagnosis. The first was actually a tracheal leiomyoma producing compression on the nerve and producing a vocal cord palsy. She was being treated as asthma. And the second was actually an intractable cough and vocal cord palsy. Patient had lymphoma. So never forget to take very basic investigation. You should always do that. Now, laryngeal EMG in the ideal center to check whether it is a paralysis or if it is a cricoarytenoid joint fixity. I generally don't do that because I do a laryngeal electromyography as a therapeutic measure only. Diagnostically, I am not doing much, but there are many European centers where they do routine electromyography diagnosis also. So, how will you diagnose? Then what you should do is, and this is a very important thing, this everybody can do. You do an examination under anesthesia and check both interarytenoid, you can click that. So, check both interarytenoid and crico. See that I am actually pressing the cricoarytenoid joint. Normally, the joint should move like that. In a cricoarytenoid ankylosis, that movement won't be there. So, put a blunt instrument behind the arytenoid and just, go back. And now play. Second one. This is checking for the interarytenoid plate. Checking for the interarytenoid. So, push one arytenoid away. If there is a posterior glottis stenosis, the other vocal cord will follow you. So that means there is a stenosis on the interarytenoid region or a posterior glottis stenosis. They also will present as an immobile vocal cord. So you should learn how to palpate the cricoarytenoid joint as well as the interarytenoid region so that you don't actually miss a diagnosis of joint problem rather than a vocal cord paralysis. Now, how you treat most of the paresis? First, of course, you make sure that everything is fine. There is no obvious lesion. You have to take a CT scan and you have to rule out a lesion. if there is no harm in giving neurotropic agents, and if there is no harm in giving steroid either, even though there are no controlled studies saying that in vocal cord paralysis the steroid actually improve. There are a lot of voice therapy techniques, but mind you, voice therapy is going to be successful only if the phonatory gap is small. If the phonatory gap is very big, say like the paralyzed vocal cord is in abducted position, if you try voice therapy, many patients will actually try lot of effort. Ultimately, they will develop ventricular band voice, which can be far more difficult condition to correct even after a thyroplasty. So this is very important, not only for the otolaryngologist, but also for the voice pathologist. Many people believe that every case can be actually treated by voice therapy. No. If the gap is very big, the role of voice therapist is preventing abnormal compensatory strategies like straining at the vocal cord, straining at the arytenoid. So that shouldn't be done. But if the gap is very small, many times the result can be dramatic. Can you put the first slide, top slide? This is just restructuring. This was only a vocal cord paresis, hardly any voice. It was actually not due to the gap, because many vocal cord paresis, sometimes they themselves develop abnormal compensatory status and produce bad voice. Second slide, can you click the second slide? No, the second one. No, go back. The middle one. Yeah. Now this is known as the half swallow boom technique, where you ask the patient to keep water in the mouth and then keep on gurgling sound. The basis of this concept is that patient learn to elevate the larynx. You can see that larynx going up, and the laryngeal biomechanics is such that when the larynx is high up in the neck, vocal cords come closer to each other. So small phonatory gap can be easily corrected by this technique. Now the final slide. The same patient, actually 1 hour after voice therapy. You can see that previously he didn't have any voice. Now hardly any problem. So, but mind you, this will work only in a small phonatory gap, not in bigger gap. Now, what is the management? Surgical, if there is a paralysis or a paresis, you can actually immediately do injection laryngoplasty. This is one of the technique. You can see that I am injecting fat there. Where you inject? Just lateral to the vocal process. So you have taken fat there, and you don't have any special needle. You can take a simple 18 gauge scalpel set, clip its wing, connect it to a 2cc syringe and start injecting fat. You can inject 1 to 1.5 cc fat on one side. You can see the left, see that the left vocal cord is getting beautifully medialized, right? See that is the medialization. This is like a thyroplasty. Immediately the voice will be improved, and see that it is completely medialized. The patient will have excellent voice. That's a very simple technique. Only problem is that patient require a general anesthesia. So when you expect a recovery, but patient cannot afford to have a bad voice for 6 months, you can do this kind of procedures. It is a day case procedure. You can send the patient home. Next slide. Yeah, there is injecting on the other side. Same technique. I don't think we'll advise that. Now, there you can do it as an outpatient procedure too. There are many techniques under endoscopic control. You can inject. You can go from the picture is through the thyroid. Second picture is through the it is not a video. Through the thyroid, and third is through the cricothyroid. Can you click the third, the last one? Yeah. So the assistant will be doing the flexible laryngoscopy. You can see the left vocal cord is completely bowed, and there is a big phonatory gap. In the glottis, material is hyaluronic acid. You can get the injection material there, either at the name of Juvedame or Restylane. So it goes subglottically, then go it to the underneath the vocal cord. Now watch, the left vocal cord is getting straighter and straighter. That gap is almost completely closing. Finally, it is completely straight. You can see that that phonatory gap is gone and patient's voice is almost back to normal. This patient had a cardiorespiratory surgery. He couldn't even cough properly. You can see the needle in the subglottis there. Now see that now it has become completely straightened. So under visualization we can inject usually 1 cc, 1 ampule of hyaluronic acid is good enough. Can you click the first slide, first video please? So this was the patient. He was on oxygen, but the problem why he was referred to, the first one, lower down. Because he couldn't even cough after the cardiac surgery. No voice. Even if hardly any voice, nothing, because, and immediately after the injection, 5 minutes later, you can click the next slide. So mind you, this is just 10 minutes after the injection on the OP, outpatient technique. Only thing is that it is going to last only 6 months. Then the hyaluronic acid will get absorbed. By the time, hopefully it must recover. Otherwise, you should do a definitive procedure like thyroplasty. Now, the definitive surgical management, established case, 6 months you do the classical medialization thyroplasty. You can see that especially for cases where the phonatory gap is more than 3 millimeter, when the recovery chance is not there. You can see that I am putting the silastic implant, suitably sized silastic implant into the window cut. And if there is a significant posterior phonatory gap, you have to combine another procedure known as the arytenoid rotation, where both vocal cords are vertically at different level. And you can see that. No, go back. Click on that. Click on the first video. Yeah. Breathy voice. MPD is very poor, 3 or 4 seconds only.
2, 3, 4, 5, 6.
Okay, next slide, next video, you click. Yeah. This is after, sorry, go back. Play on it. Second one. Yeah. Now the voice is very sharp. Excellent MPD.
2, 3, 4, 5, 6, 7, 8, 9, 10.
So previously MPD was hardly 4 seconds. You can see that it is going on. Now, there is a small subgroup where thyroplasty may not be ideal. One is children, because you can't do it under local anesthesia. Second is that their larynx is ever growing. And the third is a singer, a professional voice user. Thyroplasty will not retrieve the normal singing voice. And of course, in radiated larynx, it is better not to put an implant. In those cases, unilateral palsy, the best available treatment right now is anastomosing ansa cervicalis to the recurrent laryngeal nerve on that side. This is a classical picture. You can see that nerve is being anastomosed there, just in front of the the artery fold. So this was a case on the table. The thyroid surgery was being done. The recurrent laryngeal nerve cut on the side of the tumor. So you anastomose ansa to the recurrent laryngeal nerve trunk. You don't anastomose recurrent laryngeal nerve to recurrent laryngeal nerve, because the chance of synkinesis is very high and patient may develop bad voice. So it is better to connect the ansa cervicalis to the recurrent laryngeal nerve. Post-thyroidectomy unilateral vocal cord palsy, if surgeon is very sure about the integrity of the recurrent laryngeal nerve, he say that I have dissected out the nerve, I am sure there is nothing is wrong, it is anatomically intact, don't worry, just give neurotropics, steroids and give voice therapy. But on the other hand, if surgeon is not very sure, he didn't dissect out the recurrent laryngeal nerve, then immediate re-exploration is indicated. Here you can see that this is the case I re-explored. On the recurrent laryngeal nerve, there were 2 nodes and I had to remove that vicryl nodes because the nerve was actually not cut, but it was crushed with the node. So if the surgeon is not sure about the integrity, anatomical integrity of the nerve, you re-operate. Bilateral focal fold movement. Play this video. You can see that you take the history again and the clinical examination video. You can see that the vocal cords are not moving. Glottic space is very little, and they can have a lot of problem. So established bilateral vocal cord palsy, you hope that they will recover maybe in 6 months time. So you don't want to do a tracheostomy. Then you can do a simple surgery known as suture codopexy. Play on it. You can see that a needle is being passed underneath the vocal cord here, through which you pass a prolene there. So you can see that this is above the vocal cord now. You can see a prolene is actually coming through it, and you pass another needle through it, 30 prolene. So it will actually come out through that, pull it, tighten it, and then pull it out through the thyroid cartilage and ligate it, so that you can actually see easily lateralize the vocal cord and avoid a tracheostomy. You can see that prolene is being fed into that and then pull it out. So similarly, put in another tube below also. Can you play the next slide? This is a fine. The next one. Yeah. That is a suture codopexy now. So I am tying the suture. You can see that the left vocal cord is getting totally lateralized. So enough airway is there, so you can avoid tracheostomy and hope that the vocal cord will recover in due course of time. If it is not recovering in 6 months, of course you require different surgery. Now currently the most commonly used treatment for bilateral vocal cord palsy is, you can play on that, Kashima's posterior cordotomy. You can do either with the laser or with the coblator. It is a very predictable surgery, excellent result. Voice is reasonable. Only problem is it is irreversible. You can see that I am just cutting the left vocal cord in front of the vocal process. Anteriorly you can see the normal vocal cord, and the right side is again normal. So you are creating a keyhole shape space between the vocal cord and enough airway. In a very young children, you don't do surgery like Kashima or codopexy. You can actually do endoscope. That is not a video, that is a still. You can do endoscopic arytenoidectomy. You can see that on the second picture. You can see there is a big hole there. That is actually the arytenoid has been removed, because in the young children, arytenoids are quite bulky, and when you remove the arytenoid, they heal by secondary indentation fibrosis, and patient get a very good reasonable airway. Now very rarely only nowadays you do the external operation, which was previously used, that is known as the Woodman's operation. Nowadays, with the advent of Kashima's operation, external approach is hardly ever done, and it is now resorted to only when they are not suitable for endoscopic approach. Now what are the newer things happening in bilateral vocal cord palsy? This is a highly exciting field. Harvey Tucker and Roger Crumley were the two people who did lot of research on this. They did the nerve muscle transplant, phrenic nerve implantation, everything. And now this is a person who is doing maximum number of cases, and I am very happy to be one of his students. I went to France to learn his technique. So what is the current treatment for bilateral vocal cord palsy? You know that in Kashima, you are actually improving the airway at the expense of the voice, but current treatment is that you are retaining both voice and airway. You can see that the posterior cricoarytenoid is connected from the phrenic nerve on one side. Phrenic is a very powerful abductor nerve, because it fire for the diaphragm to contract, and for the adductors you take ansa hypoglossy. So there is lot of anastomosis. Posterior cricoarytenoid is now anastomosed from the phrenic nerve on one side using great auricular cable graft, and the adductor muscles are innervated from the ansa hypoglossy again using a cable graft. This is a very promising thing. Dr. Mahari has already done more than 100 cases. He has got excellent result, more than 80% result, and one of his students in China has done more than 60 cases. They are also good result. America, they have got now one center there, more than 10. In India, I have done now 3 cases. I am happy to say that they all are doing reasonably well. First case was not that great, but we have decannulated everybody. So that is the anastomosis phrenic to the multiple anastomosis. There basically it is phrenic to posterior cricoarytenoid and answer to recurrent laryngeal nerve. And can you play on the first slide? So this is the first case, second case and third case are actually doing better. He is a little relatively older patient. The younger patient has got a better result. He had lot of paradoxical movement at the height of inspiration. The vocal cord get see that it is getting. And can you play on the other side? See that each time the left vocal cord has started moving now. Normally, no, that is phonation and that is abduction. That much of abduction is now happening, and he has been decannulated. And the second and third, the second patient is even better. Probably, hopefully, I will be able to show the results much better. And this is even more interesting thing. This is the corresponding laryngeal corresponding thing of cochlear implant in bilateral vocal cord palsy. You can put a pacemaker to the posterior cricoarytenoid, and the person on the left side is Professor Andreas Müller, the another great man in the field, and I had experience to go there and learn this technique in pig. I think this implant will be marketed in 2019 or 2020 by the Medal company, who is actually marketing the cochlear implant. So this is going to be a breakthrough. You are going to put the implant in the posterior cricoarytenoid. So each time the patient's chest expand, it fire, and the posterior cricoarytenoid will open up. So very, very interesting things are happening in bilateral vocal cord palsy. Immediate post-thyroidectomy vocal cord palsy, how do you do? As far as possible, don't do tracheostomy. You can manage almost conservatively if there is a post-thyroidectomy bilateral vocal cord palsy. Put him in the ICU, put CPAP, propped up position, steroids, give oxygen, proton pump inhibitor. You can also knock off the adductor by giving Botox so that there is no adduction, and give rest. Of course, in a very difficult case where there is aspiration, you may have to do tracheostomy. And even more exciting finding is this: maybe all surgery will go away. There are now new selective neurotropic agents have been described. You know that the problem with the recurrent laryngeal nerve is that if the recurrent laryngeal nerve is cut, they develop synkinesis. That means misdirection of fibers. Abductor go to adductor, adductor go to abductor, vice versa. And that creates a useless vocal cord functioning. Now we have got selective stimulants. So if you inject netrin to the adductor muscle, it will attract only the adductor fibers. And if you inject glial cell dependent neurotropic factor to the abductor muscle, then it will attract only abductor fibers. So probably, maybe in the future, we will not do any surgery. We will just inject into the muscle. The neurotropic fiber will attract the regeneration of the nerve, and all these things may be a thing of future. This is really unbelievable area. Previously, we thought we were in a tunnel when we were treating bilateral vocal cord palsy. Hopefully, we are seeing light at the end of the tunnel.
Sir,
we are expecting a lot of exciting things.
We have a lot of questions actually. Maybe you can answer a few. One by Dr. Kranti Bhavana. She's asking, it's very, very useful. Need some details about Botox use in laryngeal problems. What is the role of some details of Botox?
Botox is most commonly used in adductor spasmodic dysphonia. You have to use 2.5 units into each thyroarytenoid. That means 5 units. Some patients may require slightly higher dose. Abductor spasmodic dysphonia, you can inject only on one side, because if you inject both posterior cricoarytenoid, patient will have stridor. Third common indication will be vocal process granuloma, which we discussed little early. Recurrent vocal process granuloma, the best treatment available is Botox, because it knocks off the thyroarytenoid, vocal cord become absolutely rested, there is no hitting against each other, and in 3 weeks time the granuloma will be gone. And the last indication in laryngology will be cricopharyngeal spasm. Both idiopathic cricopharyngeal spasm as well as cricopharyngeal spasm occurring in lateral medullary syndrome, which of course we will be discussing in the next topic. So you can give Botox and open up the esophagus again.
So we have one question from Dr. Siti of Indonesia. She's asking hyaluronic acid will resorb after 1 to 2 years. Do the patient need injections every 2 years or evaluation of the complaint first?
Hyaluronic acid will not last even 1 year, it will last only 6 months. So it is injected only for two groups. One, when you expect a recovery. So 6 months later vocal cord will recover. Second, life expectancy of the patient is poor. Say a bronchogenic carcinoma presenting with a vocal cord palsy, you cannot take that patient to the theatre to do the thyroplasty. So you can do hyaluronic acid injection. There is another agent, that is the hydroxyapatite paste, that is right now not available in India. It was earlier by the name Restylane. That lasts 1.5 years.
So we have one more question from Dr. Amruta TVS. Can you please suggest some books for laryngeal lesions, neurological and others? Can you suggest some books?
There is a book on Neurolaryngology by Andrew Blitzer, who is the pioneer in the treatment of adductor spasmodic dystonia. So neurological disorders of the larynx, that is the name. But of course you get a lot of books. I think the most comprehensive book will be Larynx, a comprehensive, Larynx, a comprehensive approach by Marvin P. Fried, Fried. Then of course there is a book on larynx by Robert Ossoff. There are a lot of books.
And we have a question from Meenakshi Sundaram. Good evening, sir. Is there a role of mitomycin injection for laryngeal problems?
Yeah, mitomycin can be applied where the cartilage is exposed, whether it is cricoid, whether it is thyroid, whether it is arytenoid. So to prevent granuloma. But I should say that there are no proven studies, no controlled studies saying that mitomycin prevent granuloma. But there is no harm in done. It is not very expensive. I definitely use when the cartilage is exposed in the larynx, either thyroid or cricoid arytenoid. I use 2% mitomycin for 2 minutes.
So there's one more question by Dr. Rajendran Dinesh Kumar. Is there any role for platelet-rich fibrin for injection thyroplasty medialization, sir?
To my knowledge, no, because most of the injection are either by the hydroxyapatite and hyaluronic acid.
So I am just asking a personal question from my side. Do you still do Kashima surgery or not?
Yeah, I actually give the option to the patient, because Kashima, I will tell that this is a very quick operation, very predictable operation. Only problem is that your voice will be little bit weak. It is less expensive. I will tell that I have started doing regeneration, reimplantation. I have got reasonable good result, but this will cost roughly 3 to 4 times the bill, longer stay. First 2 weeks patient will have both tracheostomy. Even if they don't have a tracheostomy at present, they will have a tracheostomy and they will have Riles tube feeding for 10 days. So I will explain everything. If patient is comfortable, I will take for regeneration.
So I think again I just want to tell some statistical numbers. 11,937 people are watching it. That is something like 12,000 people means unbelievable reach of this. I should really thank Alembic for starting this program, and it's going to continue. Next week I am going to talk on basics of endoscopic sinus surgery and also some clinical cases. I'm sure it will be very interesting. The other legends who are going to definitely visit our center are, we have asked dates from Professor Mohan Kameshwaran, Padma Shri Mohan Kameshwaran, and then Professor Sultan Pradhan of Tata Memorial Hospital, Dr. Vikas Agarwal from Bombay, and so many are going to come here, and you're all going to enjoy Saturday evenings with all these legends. Now over to the next topic by Dr. Jayakumar Menon, sir, which is going to be management of neurological dysphagia, and he is a master in it, and you're going to see how much of command he has on this subject. Over to you, sir.
Laryngology has been developing quite at a breakneck speed, and obviously it has been branching too. So there are 3 major branches already: the voice or the phonosurgery, the airway tract stenosis for the laryngotracheal stenosis, and deglutology or the speciality of dysphagia management. Now this has been a major problem. Lots and lots of patients all over the world has got dysphagia, especially from the cancer, head and neck cancer surgery, and also from the neurology and neurosurgical wards. And our understanding of the swallowing was not very great. Even now it is not very great. But I am happy to tell that among the 3 subspecialties of the laryngology, dysphagia is improving by leaps and bounds every year. It is one of the top specialty. Many people in America are just concentrating on dysphagia alone because it is high regarding speciality. And so I have got actually a dysphagia unit in Amrita, Cochin. So I am a visiting consultant there. I actually do only swallowing there in Amrita. In KIMS I do all the 3 branches of the laryngology. Now, neurological dysphagia, I think I am sure that every one of you know there are the different stages. The oral stages has got the oral and preparatory and the oral proper, and you can play on that video. And the pharyngeal and esophageal stages are there. In most of the neurological dysphagia, you actually get the problems are either in the oral stage or in the pharyngeal stage. So this is a classical video fluoroscopy showing the picture, how the bolus is going. Fluoroscopy is a very important tool in assessing the swallowing mechanism. Now, what are the common causes of neurological causes? So we are not taking into consideration the head and neck cancer at all. So that is a major group. So the major common causes of neurological causes of swallowing is, one is the brain stroke or the lateral medullary syndrome, or otherwise known as the Wallenberg syndrome. Many times they will have only one complaint, swallowing. They are otherwise okay. They don't have any limb movement or any problem. They will just wake up one day saying that I cannot swallow anything. So that can present like that. Motor neuron disease is a very difficult condition, very frustrating condition. Treatment is very, very difficult. Parkinsonism is the condition which can affect all the stages of swallowing. And of course, many neurosurgical procedures, especially of the posterior cranial fossa, like foramen magnum decompression, Arnold-Chiari malformation surgery, the acoustic neuroma surgery, they all can actually create problem with the swallowing. Now, this is a huge topic, so I will try to make as simple as that. So I believe that any complex topic should be oversimplified, then only it is easy to understand. So this is a very complex topic. So I'm just going to make you understand this way. All group of swallowing patient can be put under 3 major headings. Either you treat with indirect swallowing therapy, or direct swallowing therapy, or interventional therapy. Means you do surgery. Now, if you can call the surgeries done to improve the voice phonosurgery, there is no reason why these surgeries can be called phago surgery. This is my own creation. So I have written it in few textbooks, this word, because there are a group of surgeries which are designed to improve the swallowing. So any surgery done to retrieve or improve the swallowing can be called phago surgery. So we will see what are these conditions, what is indirect swallowing therapy, what is direct swallowing therapy, and what is interventional therapy. Now, going back, before going to each and every one, indirect swallowing therapy means you actually don't give food to the patient, but you design certain exercises where you strengthen the already weakened muscle. I will show more and more examples so you will understand. So indirect swallowing therapy means you won't give food to the patient, you will just strengthen the muscle. Say for example, patient has got a palatal palsy, patient has got nasal regurgitation. So what is the indirect swallowing therapy? You design certain exercises where the palate muscle will become strengthened, like blowing a balloon. So that is an indirect swallowing therapy. What is direct swallowing therapy? You give food, but you modify it. You don't give a standard. You modify it in different way. You may modify its texture, you may modify its temperature, you may modify its volume, you may modify the position in which the patient has to swallow, you may tell the techniques to swallow when patient has got cough or something like that. And interventional therapy is a surgery. So with this basic understanding, we will just run through few of the neurological condition and how you can see to help them. Now imagine patient has got an oral preparatory phase problem. This patient had a skull base surgery in Bangalore, and you can see that her right facial palsy is there. So what is the problem? She has got a gap. The lips are not closing thoroughly. So patient cannot really swallow, and buccinator is paralyzed. So what will happen? The food will always get collected in the oral vestibule. So two problems she will have. She will have problem, the food will drool out and the food bolus will get collected in the vestibule. Can you click on the X-ray? Not on the picture. Yeah, you can see that. See that there is no lip seal. You can see the barium is actually coming out, and even after swallowing, there is a lot of barium in the oral cavity. That is in the vestibule because the buccinator is paralyzed. So buccinator cannot actually send the food back to the oral cavity proper. So that is a very, very common condition. So how do you treat them? So we have seen that indirect swallowing therapy. We know that the patient has, mind you, most of the swallowing therapy techniques are very simple techniques. All of you can follow if you understand it properly, the pathophysiology. So imagine patient has got a lip weakness. What you will do? You do a lip strengthening exercise. So one of the commonest simple lip strengthening exercise is known as the button and thread exercise. You take a very big button, anchor it very strongly to a twine, keep the button inside the lip but outside the teeth, and ask the child or the patient to hold on to the button with their lips, and at the same time the caregiver will be pulling at the twine, so that you are actually developing muscle tone. This is a very efficient technique. Gradually the length power will come. And what will be the direct swallowing therapy technique for this patient? Suppose the right side is paralyzed. Very simple. You give the food through the left side of the mouth, or ask the patient to turn the head to the left. So that with the gravity, food will go only to the left side. So on the side of facial palsy, the food will not get collected. Very simple technique. What is the surgical treatment? Phagosurgery. You do the masseter transfer or the temporalis transfer. So each and every condition will have indirect swallowing therapy, direct swallowing therapy, surgical therapy. So direct swallowing therapy will be, can you play that? You avoid the abnormal side. Feed it through the normal side. And also you can tilt whatever way, whichever way to prevent. So they all are very, very simple common sense technique. Most of the swallowing therapy technique, if you understand the mechanism, it is much easier to treat. You have to understand the physiology, the pathophysiology you have to understand. Now oral preparatory phase. That means again we'll see another facial palsy case. Can you play on the video? See, you can see that there is plenty of bolus in the vestibule. This is the buccinator paralysis. You can see that even after the tongue has propelled the mass into the oropharynx, there is plenty of barium still in the oral cavity. Since it is in the lateral view, you can't understand. But if it is in the AP view, you can see it is clearly outside the teeth. But here you can see that the barium is still there. That is the classical buccinator paralysis. So how you manage? Indirect swallowing therapy will be muscle strengthening. Ask the patient to blow. So the buccinator will strengthening. What is a direct swallowing therapy? Again, avoid the side. Go to the normal side. It is very easy. Now, you can have inability to chew. Can you play? In a fifth cranial nerve palsy, you can actually have a lot of problem like, the mandible will not be chewing properly. So they can have a lot of other problem. We will come to that. I think we'll skip that. So what you do? You give blended diet. So this is what is known as the modification of the diet. Some patient will require some kind of food. So in swallowing therapy, in direct swallowing therapy, you have to modify the diet. You have to modify the amount. Some people cannot take 30 ml of water at a stretch. They have to take 5 ml each, but they still be able to drink. A patient who has got a narrowing will not be able to take solid food. You have to give liquid. A patient who has got a vocal cord paralysis will not be able to take liquid food. You have to give them semi-solid. So adjust that way. Now, bolus propulsion is poor. Some patient has got a tongue paralysis. This was a patient who underwent Arnold-Chiari malformation surgery. Play on it. You can see that it's a bilateral hypoglossal palsy. Very unfortunate condition. Patient cannot send the food into the oropharynx proper at all. So patient is struggling there, the food is entirely in the oral cavity. What you do? What is the indirect swallowing therapy? Do the tongue muscle exercise. Keep on doing. Apply heat, some honey on the lip. Ask the patient to try to lick around, both clockwise and anti-clockwise. So keep on stimulating the tongue. Stretching the tongue will move. What is the direct swallowing therapy? Provided patient's laryngeal stage is normal, you can actually bypass. Click the second video. See, patient has got a tongue paralysis, patient is unable to get. So what this is known as the jet feeding. You take a polythene cannula, make semi-solid diet and put there into the pharynx and put it. That is as simple as that. Patient swallow. Mind you, posterior pharyngeal wall and palate has got taste buds. So patient is not just having a tube feed. Patient is enjoying the taste of the food. Patient is avoiding a feed. So this is the jet feed. You bypass this all. That is what I tell. All swallowing therapy techniques are common sense technique. It is pure basic common sense. How you can go about. That is a wonderful concept. And you can also use gravity. Click the first slide. If the tongue is not propelling, what will you do? You ask the patient to lift the head so that the tongue will act like an inclined plane over which the fluid will flow over it. You cannot give solid, but you can always give liquid. Now, sometimes Parkinsonism can be a very, very difficult condition. Can you click on that? This is known as the swing movement of the tongue. First, the anterior part of the tongue will rise in the oral cavity, then the posterior. Unfortunately, the food will move like a swing from to and fro. So, it is an incoordinate movement of the tongue. It is a very difficult condition in tongue. In Parkinsonism, the tongue is keeping on moving. So, what you can do, what is known as effortful swallow, what you do is ask the patient to squeeze it down. You can see that the whole larynx gets squeezed, pharynx open up. This is known as the effortful swallow. Now, velopharyngeal incompetence, where patient has got a lot of nasal regurgitation. Here you can see that into the nasopharynx also is the barium going up. How you go about it? So, the patient has got tongue palsy as well as a palatal palsy. Again, do the palatal exercise, the indirect swallowing therapy. What will be the direct swallowing therapy? Again, a very simple technique like nose pinching or chin tuck. First video, please. Watch this massive leak through the nose. That is huge. But now, watch it. Make her eat normally. So when you pinch the nose, there is a back pressure, and many times it will actually prevent. And so next video, click on. You can see this is chin tuck. When you tuck the chin, when you flex the chin, because of the fulcrum effect, the soft palate go and touch the posterior pharyngeal wall better. So many of the nasal regurgitation will be prevented if you ask the patient to swallow in head down position. Ask the patient to touch the neck. The anterior chest wall with their chin. So that is known as the chin tuck. So you can see that nasopharynx get completely cut off and you can actually swallow much better. Suppose still it doesn't work, there is an operation called palatopexy. So here you can see that on the left hand side is a soft palate, and on the right hand side you have seen that I have taken both posterior pillar as a superiorly based flap and rotated across the posterior pharyngeal wall, so that the velopharyngeal sphincter has become very, very small. They may snore a little bit, but their nasal regurgitation will come down significantly. Now, laryngopharyngeal paralysis can be a very, very difficult condition. You know that the basic condition in swallowing is that the larynx has to elevate. You watch the patient when they swallow, the larynx has to elevate. If the larynx is not elevating, you call it laryngopharyngeal paralysis. This can happen in motor neuron disease as well as in diseases of the mandible where you have resected the symphysis mendae. They can be very difficult condition. One of the most difficult condition in swallowing disorder. Patient can have real swallowing problem. Can you click on the next video, please? Next video. The patient is attempting to swallow, but it's not going really. The larynx is not elevating. This is one of the worst prognostic condition in swallowing. If the larynx is not elevating, the swallowing will not be very great. So that what you can do. So indirect therapy is what is known as the shaker exercise, after the famous gastroenterologist who invented the the transnasal esophagoscope, Rasa Shaker. So he described this technique. Ask the patient, click on that. Ask the patient to lie down flat and lift the head off the bed against the gravity. Try to keep it as long as they can. So what will happen? The suprahyoid musculature will get strengthened and strengthened. Every day they do it. So when the suprahyoid musculature gets strengthened, laryngeal elevation become better. You can do what is known as the Mendelssohn's maneuver, that is the direct swallowing therapy. So if the larynx is not going by its own, keep the food in the mouth, you catch hold of the larynx and elevate. And you can also do the chin tuck, because when you tuck the chin, you stretch the cricopharynx and it open up. Watch this patient, he was struggling. Now with the cricopharynx, with the chin tuck, watch the barium flowing almost normally. You can see that. See that almost normally when, because when you stretch the cricopharynx open. So if the patient's larynx is not elevating, one second option is chin tuck. You have seen that chin tuck is also useful for velopharyngeal incompetence. Hyoidopexy is many times done by the snoring surgeon, but our surgery, the swallowing surgeon, the deglutologist do in a different way. Here you do both thyroid, you anchor the hyoid to the mandible. In the first picture you can see I have taken the Prolin suture, and in the second picture you can see that you have also obliterated the thyrohyoid space. So you obliterate the thyrohyoid space by anchoring the thyroid and hyoid together, and then anchor the hyoid to the mandible, so that larynx is permanently in a higher position under the protection of the tongue base. And also when you are elevating the larynx, it causes cricopharynx to relax, because cricopharynx is always in a contracted state. It will open only if it is stretched, and if larynx is not elevating, cricopharynx won't open up. That is the problem with the laryngopharyngeal paralysis. So in difficult cases, you can go for hyoidopexy.
Sir, we have a few questions. I think we can answer them. R.K. Jha, Dr. R.K. Jha is asking us how to diagnose functional aphonia.
There is a question now. Okay, shall I go about? Yeah, functional aphonia means vocal cords are normal and patient doesn't produce any voice at all, absolutely no voice. But you ask the patient to cough, he will cough. Vocal cord is in a way like liver. You can take out 90% of the vocal cord, you still have some voice. So if somebody is just producing absolutely no voice, you should suspect that you are dealing with a functional aphonia. Even if only 10% of the vocal cord is there, there will be some rough voice. So that is one indicator. Second is that they will be able to cough normally.
Thank you, sir. You can continue, please.
Now, pharyngeal dysphagia, you can have laryngeal incompetence where the vocal cord is paralyzed. Can you click on the first video? It's not playing. Oh, just click on that. Just click on that. Okay. You can see that the right vocal cord is immobile and there is a lot of pooling, and gradually the saliva in the pyriform fossa is going into the larynx. So this happened in 10th cranial nerve palsy. You can play the next video, and the fluoroscopy show massive aspiration. It's not playing. Can you play this? Go back to the I'll come back. Now play that video. Now play the second video. Okay, leave it. That was an aspiration. So if there is an aspiration, what you can do? Now this is not, there are two techniques. One is known as the supraglottic swallowing. Second is known as the super supraglottic swallowing. What are they? It is very simple technique. They are very efficient. Suppose patient's one larynx, hemilarynx is not closing and patient is aspirating on liquid. In supraglottic swallowing, what you do is you keep the food in the mouth, ask the patient to hold breath and swallow, and he shouldn't release the breath till he is completed. Can you click on that? So this is a supraglottic. And no, wait, it will play. No, 1 minute. Oh, sorry. What happened? I now play on that. It's okay. No, next one. You can play on the next one. There is some video. Okay, I will tell what exactly. In super supraglottic swallowing technique, what is happening is that not only you will hold the breath, but also you will do the bearing down maneuver, or this is Jendrasic maneuver. Ask the patient to hold it tight and keep on tightening and hold the breath. Oh, sorry. Yeah, hold the breath tightly and then swallow. Now you can see the lower picture, they are not video. Look at the middle picture where both vocal cords are not closing. Now look at the left hand side picture. This is what happens when you do the supraglottic maneuver. See, the arytenoids are coming closer to each other and it is almost coming to epiglottis. So this is a supraglottic, and see on the right side, super supraglottic, it gets completely close. You know, the larynx get totally close. Epiglottis get jammed against the posterior pharyngeal wall. So the chance of aspiration is hardly anything. Can you click on the first video? This is a supracricoid partial laryngectomy, had massive aspiration, huge aspiration. See that 50% goes through the front root, that is the larynx. So teach him the super supraglottic swallowing technique. Watch the next video. First he didn't learn, he had aspiration, but a little later you can see that. Now this is his first attempt at the super supraglottic. That was not successful, he didn't learn it. Now see that he could actually control the thing and totally prevent aspiration. So it's a very efficient technique, excellent technique to prevent aspiration. Now sometimes neither supraglottic or super supraglottic can prevent, then you can do actually type 1 thyroplasty and arytenoid rotation. So originally, which is a phonosurgery, here comes back as a phagosurgery. Now watch this patient. Can you go a little forward on that slide? So that no, on that slide, on that video, same video. Go a little forward, a little more forward. Yeah. Now he is trying to little backward. Little backward. Yeah, there. Yeah, he is trying to drink liquid. Watch. He has got a unilateral vocal cord palsy with superior laryngeal. It went in, immediately came back. He aspirated. He cannot. Now, can you click on the next video? That is the after thyroplasty. No. Video. Click on the video. Now you can see that the tube is gone. He has got occasional mild cough, but he is drinking thin liquid. Now if a patient has got a unilateral vocal cord laryngeal incompetence, if he is drinking thin liquid, that is the end of the therapy, because that is the most difficult thing to drink. Solid will not leak, liquid will easily leak. So thyroplasty can be very useful at that time, and sometimes you may have to do cuff tracheostomy. And in very rare cases where the aspiration is intractable, I prefer to do this surgery. This is known as the laryngotracheal separation or disjunction. You separate the larynx and the trachea and close down the lower end of the larynx so that nothing goes down, and bring the upper end of the trachea as the tracheostomy. If and when the aspiration problem come back, patient is okay, you can do the reanastomosis. But reanastomosis is a little bit difficult procedure. Only people who do regular tracheal resection can do this surgery, because you have to do just like a tracheal resection, you have to anastomose again.
So we have a few comments and questions. Just want to inform that we are being seen by 15,620 people. 15,620 people which are who have been
really
reached.
gratifying. I'm happy to know that people are listening.
Yeah, and a person called Sanjeet Mishra has written, sitting glued to my mobile screen without a blink. Okay, now a question from Dr. Nandini. Sudden hiccups. This is very common. Sudden hiccups while swallowing food, even after drinking water. So this is something which everybody wants to ask you.
I also probably cannot have a very definite answer, but one of the cause of that kind of thing is that obviously this is irritation of the diaphragm. We all know that the hiccup is actually due to the irritation of the diaphragm get irritated. So how the diaphragm get irritated? Either the phrenic has to get irritated, that is very unlikely. So usually what happens is that some amount of an air bolus gets stuck in the stomach fundus, and it keep on irritating the to the fundus. So it stimulates the diaphragm and keep on doing that. So positioning, drinking water, all may be okay, but probably many time a simple treatment like Gelusil MPS, which is a methyl polysiloxane, which is a known anti-flatulent, that the air antagonist will actually cure. You can also give a domperidone like prokinetic agents.
So we have Arun Nair asking about the future of laryngeal transplants.
Laryngeal transplant is already in the vogue. Only problem is that the ideal cases are as of now very few, because the commonest cause of laryngectomy is cancer, and you don't do laryngeal transplant in a cancer because you have to give an immunosuppressant. You won't give an immunosuppressant in a cancer. So right now the indication for laryngeal transplant is a young patient who has lost his larynx in a trauma, and mind you, all the three functions of the larynx has to go, because both airway, voice and swallowing. Then if there is the ideal donor, you can do that surgery.
So you can continue, Professor.
Now pharyngeal paralysis, if there is no squeezing effect, suppose this patient has got a hypoglossal paralysis, pharyngeal paralysis on the right side after a schwannoma operation, and a simple technique of avoiding the right side, turning the head, tilting the head to the left. You can see that with the gravity. When patient is shifting the gravity, simply because of the gravity, whole fluid go through the left side. So there is no chance of fluid going through the paralyzed pharyngeal pyriform fossa and then causing secondary aspiration. That is very simple technique. Next slide. Next, you click on that. This is the effect of turning the head. Watch this. Patient is lying down on the right side, on his right side. And when patient is lying on the right side, so in a right sided position, you can see that whole food went through the right pyriform fossa only. You can see that colored fluid going there. So this is a very efficient technique. Suppose patient has got a left pharyngeal paralysis. Of course, this patient doesn't have a paralysis, it's only a demonstration. Can you play that video once again, the second video? So if you want to avoid one pyriform fossa, just ask the patient lie on the opposite side. You can see that now the whole colored fluid was going only through the right side because patient was lying on the right side. That's a very simple technique. So if there is a left pyriform fossa paralysis, ask the patient to lie down. Here the patient is lying on the right side, so whole food will go only through the right side. That is a very simple technique of avoiding aspiration. Now, this is very interesting to note. What will happen when you turn your head? This is a still picture. Watch the middle picture. You can see both pyriform fossa are open. You can see it. Now on the left hand side, patient has turned the head to the right side. See that what has happened? Right pyriform fossa was got completely obliterated and left pyriform fossa became much open. And see on the other side, right hand corner, patient has turned the head to the left. And what has happened? Left pyriform fossa got obliterated and right pyriform fossa became open. So this is a very useful technique. Whenever you want to open up one pyriform fossa or you want to close a paralyzed pyriform fossa, you can judiciously turn the head, and this can be done with visual feedback. You can even show the patient, put the flexible laryngoscope, put him in front of the mirror, ask him to turn and see that, look, now you are going through the right side. So this is the video evidenced swallowing therapy technique. Now if one pyriform fossa is hopelessly paralyzed, there is plenty of pooling. There is a simple surgery known as obliteration of the pyriform fossa or hypopharyngoplasty. Anybody who does thyroplasty and retinorotation can actually do that. You can see on the right side, there is a bulge, a bubble-like thing in the middle of the picture. That is a pyriform fossa. Mind you, this is done under local anesthesia. When you swallow, you see the pyriform fossa bulging. Just plicate like a hernia. You just close it off with the prolin so that the funnel-shaped pyriform fossa become semi-funnel shaped. Paralyzed pyriform fossa get completely obliterated, so there won't be any pooling and there won't be any secondary aspiration. Now you can have cricopharyngeal dysmotility, which is very common in brainstem stroke and sometimes in idiopathic condition also. Watch this case. This is a lateral medullary syndrome. Patient is trying to swallow, the cricopharynx is not opening up. It is simply staying there, and after some time it actually falls back into the larynx. So patient can have a delayed cough. That's a very difficult condition. If it doesn't clear in 6 weeks time in lateral medullary syndrome, you need to intervene. Can you click the next? This is an idiopathic cricopharyngeal spasm. Happen in older people, especially ladies. In the lower part of the video, you can see big indentation of the posterior pharyngeal wall of the esophagus. You can see that is the idiopathic cricopharyngeal spasm. This happen in many middle-aged, that is after myotomy. You can see it is going very well. We'll come to that. Next slide. Sorry. Now, the first treatment will be Botox. You can inject under the electromyographic control, and you saw the first patient where the cricopharynx was not opening. The same patient below, can you click that video? Below video, first video. Below, yeah. The same patient who was not opening up at all, 18 days after injection, you can see that the bolus is going normally, patient is swallowing normally. So Botox can do wonders in lateral medullary syndrome early stage. Can you click that surgical video, the red one? The red one. That is a cricopharyngeal myotomy. So if Botox is not working and it's a long-standing case, you can actually open up the neck. That is the esophageal mucosa. You don't breach the mucosa, but you cut the entire cricopharyngeus muscle. And mind you, cricopharyngeus is not just confined to cricoid. To be a successful cricopharyngeal myotomy, you have to cut the muscle all the way down to the clavicle, because there is a lot of interlacing fibers with the esophagus. So to be a successful cricopharyngeal myotomy, you have to cut not only the cricopharyngeus but also the upper esophageal fiber. Now click the last video. This was a patient who had medullary carcinoma surgery, and after radiation patient had severe obstruction. It was very difficult, but this is a cricopharyngeal, same patient. Yeah, you can see that big cricopharyngeal spasm, and after cricopharyngeal myotomy you can see that patient is swallowing much better. Now we are about the end of this today's program. What is cortical stroke? You know that you will see many patients with the middle cerebral artery stroke. The neurologist will say that patient has got a middle cerebral artery stroke, patient is not swallowing. Actually, cortex has nothing to do with the swallowing. Swallowing technique is intact, but patient simply won't swallow. This is known as swallowing apraxia or swallowing agnosia. Apraxia means patient doesn't know the food is for swallowing. So he simply won't swallow. He will put the food in the mouth. His swallowing technique is perfect. He won't aspirate, but he won't swallow. And what is swallowing agnosia? He doesn't even know that food is in the mouth. They can be very difficult condition. It occur in middle cerebral artery stroke. It is worse on the left side. If it is a left middle cerebral artery stroke, these chances are high. Right side, younger patient, left side many times take over and they have got good response. So even though their swallowing technique is, mechanism is perfectly alright, there is no risk of aspiration pneumonia, they will still require some kind of a tube feeding. So ability to enjoy food is one of the most primary requirement. That is why deglutology is one of the most gratifying specialty in ENT. Because I know that as a laryngologist, I have retrieved the voice of many people. They are very thankful to you. But it is nothing when compared to the patient's gratitude in whom you have retrieved the ability to eat and drink just like a normal person. If you can't eat and drink, then what is the point in living?
So that's a very exhaustive 3 lectures. Thank you, Dr. Jayakumar sir.
Thank you.
In fact, we have a lot of questions. Dr. Sambaji Chintale has asked, what is the treatment for globus pharyngeus?
First of all, you have to make sure that you are not missing anything. So, globus, 5% of the lower esophageal pathology can actually present as globus. So, before branding them globus, do a thorough examination, do a flexible laryngoscopy, and if in doubt, you do a esophagoscopy. If you have got the facility to do the esophagoscopy yourself, like transnasal esophagoscopy, great. Otherwise, you ask your surgical gastro or medical gastro colleague to do the esophagoscopy. If they are all right, then you can treat globus with pantoprazole, and sometimes you may have to do an antipepsin agent too. And many times reassurance will be okay, and you have to change the lifestyle measures.
So we all really thank. Actually, it's an unbelievable response of 16,955 people who have been reached by this program from around 17 or 18 countries. We don't know. Tomorrow we'll give you the exact list of how many countries have been reached. Around 16 to 17 countries have been reached. And this is just the start. You have seen the real Doyen. You know how nicely you all enjoyed his lectures. In fact, the next week what we are planning is I'm going to talk on basics of endoscopic sinus surgery, and it's going to be a 2-day program. So initially on a Saturday evening you'll be having a lecture for around 2 hours. That is some videos on cadaver demonstration, as well as some clinical videos on basics of endoscopic sinus surgery. We'll discuss all the questions like we did today, and then the next day will be a live surgical demonstration of a few FES cases on Sunday, and that is the program for the next week. I'm sure you will all join us for next week. This week, in fact, Dr. Jayakumar sir is going to operate on a few cases, but unfortunately we didn't plan for transmission. Maybe we will plan for it later. We have contacted legends like Professor Sultan Pradhan, Dr. Vikas Agarwal, and also Professor Padma Shri Mohan Kameshwaran sir, and we'll all be seeing them on Saturday evenings. Really thank Alembic, Mr. Rajit, and also the whole team who is right here, the whole team in Trichy, for this wonderful program and the reach which they have created for this, and the expectation for a Saturday night. And this is truly unbelievable, and this is the way to go, I believe, the method of teaching. And there are so many postgraduates who will benefit from this. And really thank you, sir, for coming over to Trichy. And I would like to just end this by asking you just a question. I think I feel totally outdated after seeing your talk on laryngology. So what is your advice to the youngsters out there, the postgraduates who want to start a career in laryngology?
Yeah, I think just like any other specialty, ENT is also developing very fast. And I always believe that there are, in any specialty, there are 3 levels. One is the generalist. That means you do everything. So in the beginning stage of your career, you have to do that. You have to do tone, you have to do throat, you have to do nose, you have to do ear. Because then only you will know the attitude, and you will have the aptitude. Then the next stage is you have to upgrade it to the level 2. That is the generalist with special interest. Because you may select laryngology. But in the beginning, you cannot survive on laryngology alone. So what you are doing, you are going to do general ENT alone also. But mind you, you will concentrate on laryngology or whatever, otology if it is. And you will publish and present paper only on laryngology. That is very important. If you talk about otology today, rhinology tomorrow, head and neck surgery day after tomorrow, nobody is going to take you seriously. But if you keep on talking on one thing, people will know that, okay, you are there. So that is the English level. You are going to level 2, generalist with special interest. Now the last level is a super specialist. That is optional. If you want, you can become a super specialist like what I have done. And I don't do ear and nose, but it's up to you. So society need all the 3. The village, the rural area require the generalist. The bigger towns require the generalist with the special interest, and the higher referral center certainly require the super specialist. So by the time you have got enough time to develop specialty, so you are not under pressure to earn. If you take a specialty, if you tell that I am going to practice laryngology tomorrow, you will struggle because you won't get enough case. So that is how you should be going.
So thank you very much, sir. I think the youngsters really enjoyed that final answer of yours. So level 1, level 2 and level 3. And just want to advise those of you who really want to choose the level 3 or the level 2 that the most important thing is project yourself in one field. Excellent. Or else you will not be equated to that particular area. And that is very important. Don't project yourself as a rhinologist, as an otologist, as a implantologist and everything. So that will lead you nowhere in this world, because the world is moving towards the highest focus in every field. Thank you very much, and have a very good night.
Thank you. Good night. Good, unbelievable. 16.